some countries have seen. Obviously, that's no space for complacency, and it seems to be at the moment that the majority of cases have a direct or indirect link to overseas travel. And what we're seeing is cases emerge from people that came into the country, mainly New Zealanders who came back from overseas over the preceding 2 weeks, who have developed COVID-19 and who have either then become ill or passed the condition on to people they were in direct contact with. As you may be aware, there's a number of small clusters around, or small or moderate sized clusters around the country, like in Matamata and Queenstown. We haven't got very widespread community spread at this point in New Zealand, as far as we're aware, but there have been a few cases. And the whole point of this lockdown is to try and prevent community spread of the disease and prevent a large number of cases coming through that might overwhelm or severely damage our healthcare system and cause a lot of people becoming ill at once. It would make it very difficult for us to be able to treat people adequately. Those of you who have blood cancers will already be noticing changes. So what we've done in the healthcare service is try to preempt some of the situations that have happened overseas. So some of the differences are that we're doing a lot of things by telephone consultation, where we might have seen patients in person before. And one of there's several reasons for that. One of them is the public health component, to try and really do what we can to support that staying at home and that all those measures to prevent spread, making sure we're doing our bit with our clinical situation. Another thing is directly for you or your family as patients, to try and avoid you coming into hospitals, which are often the place where the condition can spread, because that's where people who are ill will gather. Another situation is also to make sure that we're minimizing the general strain on our healthcare service in case we get a very large bulk of patients coming into hospital with COVID-19 disease at once. I believe there's around 14 patients nationally in hospital with this condition so far. So it's certainly the case at the moment that our inpatient units are actually much quieter than normal at the moment. Our hospital's running, my own hospital's running at about 50% capacity. We normally run about 90 to 110% over the winter months. So actually it's much quieter, and that's just because a lot of non-emergency operations and procedures have been cancelled, so the hospitals can focus on preparing for this. You may have noticed around the country, intensive care units have been preparing and scaling up, enlarging their units or adding negative isolation rooms to prepare for this. There's been a lot of staff training happening in wearing protective equipment and how to work in different areas. And we've taken a lot of precautions about our staff, so that we have certain teams that work with the COVID wards and certain teams that don't, so that those people who come in with more regular medical problems aren't being seen by the same members of staff who might have been treating patients with confirmed COVID-19 disease. So we're doing a whole host of things to try and prepare for the possibility of a larger number of cases, but also to try and protect those of you who are coming in with other conditions and make sure we don't make you sicker than when you come into hospital. So there's quite a lot going on in our hospitals to prepare for this. At least at my own hospitals, we've got now community-based assessment centres, drive-through centres for testing, and a lot more testing happening or will be happening in the coming days as we start to move into testing people in the community as opposed to just testing people who get admitted to hospital. So that's where things are at the moment. We're really hoping that with, I think, very stringent measures New Zealand is taking, and also very early measures, that we can avoid some of the most severe problems that have been affecting places like Italy and perhaps more recently the UK and United States. And hopefully we're ahead of the game with the things that we're doing at the moment. Now there's a number of questions come through on the Q&A. I might just address those because that might provide some other focus for some of the questions. So we've got a question from somebody saying, I'm 69, I have AML, been remission for 18 years, normal medication-free happy life. All my friends and families are worried for me. So am I more at risk than an average 69-year-old? So by the time you're 18 years out of a bone marrow transplant, and I presume this is an allogeneic bone marrow transplant, where you got the immune system from somebody else, as long as you're off immune suppression, probably your immune system is now getting pretty close to normal. It does take quite a long time. It probably takes several years after a bone marrow transplant for the immune system to recover to normal, and that can be delayed even further if you're still taking immune suppression, for example, if you have graft versus host disease. But by the time you're 18 years out from a bone marrow transplant, hopefully that new immune system is near normal. Bear in mind that none of the rest of us have immunity against COVID-19 disease either. So your friends and family won't be immune to it. I just raise one precaution generally about this. We know that everybody's potentially at risk of this disease. So that doesn't mean there's no risk. I'm just saying you're not necessarily at hugely increased risk compared to those around you. But that does depend on, at age 69, there is an age-related risk. Then you may have other conditions such as high blood pressure or diabetes. Those things would be risk factors as well. But in terms of the prior acute myeloid leukemia that's now a distant history, bone marrow transplant many years ago, the risk probably isn't much more than background. And I just suggest paying close attention to the government recommendations about social distancing. Probably at this stage, to my mind, wouldn't fall in the highest risk category of patients with active cancer on chemotherapy. I'd be more concerned about the first months or year or two after an allogeneic bone marrow transplant. Another attendee asks another transplant-related question. So a son who is in his early 20s and 1.5 years after a bone marrow transplant, lives at home. Father is a doctor and mother is a nurse, and he's currently off medication. So within a couple of years of bone marrow transplant, there probably is a bit more immune compromise. Up early on after a transplant, it's sort of like you have to regain your immunity. It's like starting again from a child. And any of you who've had or know people who've had an allogeneic bone marrow transplant may know that by the time people get about a year out, it's quite common to repeat the childhood immunizations. Now, whether that's a problem for COVID-19 disease or not, we don't know. I mean, even newborns don't seem to be at huge risk of this disease, but he might be at somewhat increased risk for that early stage, 1.5 years after transplant. And I would suggest he takes some precautions. In terms of having family members who are working in healthcare facing, sort of patient-facing roles, that is worth bearing in mind. And I think if he's at home and there's a family member who is seeing a large number of patients or a large number of people who could have COVID-19 disease, there may be a role for trying to set up a bit of a firewall at home if that's possible. There's a little bit of information on the Ministry of Health website about living with other people. It's more based around flat shares, I think, than family members, but some of that advice about considering if it's possible within your home. I don't know if it's possible whether to use separate bathrooms. There's other sorts of simple recommendations like avoiding sharing towels. You might be able to see if you could take a few precautions like that. On the other hand, moving entirely and then setting up another bubble might then be counterproductive. So possibly at moderately increased risk, 1.5 years out. And I think if you can try and put some of those isolation things in place at the home, it might be sensible. It is quite difficult to avoid things entirely within a home environment. And the best thing we can do is what we're all doing as a society, hopefully, which is to try and prevent the community spread altogether through the measures that have been taken at the moment. There's 1 or 2 questions come through on, so what Graham asks, do you think remote medical consultations are here to stay? Well, I think they probably are actually. And at least in our own centre, we've been using these a little bit more. In fact, about 2 years ago, I set up a separate telephone clinic, and that's for a number of reasons. One of them is really, it's a credit to the success of a lot of our treatments. A lot more people are living with blood cancers rather than being necessarily ill with them. And success for a lot of blood cancers is essentially turning these conditions from something that might have had a very poor outlook into a chronic illness that maybe is more like having diabetes or high blood pressure. It carries risk factors, but many people will live for many years with this condition getting on as normal. And we've seen that with chronic myeloid leukemia for many years, and we're starting to see that with CLL and myeloma now. So I would say we've got 2 things going on, which is that our clinic's getting busier, and this is a good thing. It's mainly because people are living better, hopefully mainly healthier lives with their blood cancers. And the second thing is that, thank goodness, but some of our newer treatments for some of these conditions are less toxic than they were. So that enables us really to let people be at home and perhaps just review their blood results and give them a phone call. And I think for most patients I talk to that about, they're delighted not to have to come into hospital and drive a long way and pay for parking, navigate the traffic. So I suspect that I've got lots of colleagues that didn't make much use of telephone consultations who are now saying, oh, hey, this works really well, and my patients seem to really like it. So I suspect we will see a lot more of it in the long run as well. I don't think we'll do everything by telephone consultation. It's really not ideal, but I think we'll do more of it. And if we can do that and use that sensibly, then I think that's a win-win, hopefully for patients and for hospitals in terms of managing a larger number of people without necessarily using a lot more resource. So yes, I think we probably will see a lot more remote consultations in the future. There's one or two questions come through on the chat, which I'll just answer. Just encourage you to put them on the Q&A rather than the chat. Are patients switching from Velcade to oral tablets in some cases? Yes, so there's a lot of discussion. There's a number of working groups of hematologists, something called the hematology working groups in New Zealand. There's also groups in Australia. And in the background, what a lot of us have been doing is speaking to each other, looking at guidance from overseas about trying to find ways to adjust people's treatment so they can visit the hospital less. Velcade or bortezomib is one of those drugs where it is given by injection, and usually that's in a hospital. In our own center, we're seeing whether we can actually allow patients to self-administer that at home. It can be made up with a 2 or 3 week expiry. We've just got some questions around how we transport it and how it can be stored and all those sort of things. So one option is to try and look at more home administration of some of these medicines for those who are able. And yes, another option is changing or modifying people's treatments entirely to favor oral regimens. Pharmac is actually looking at temporarily changing some criteria to allow us to use oral therapies where we couldn't before, at least temporarily. Obviously, they still will have their budget to deal with and the cost considerations, but we are actively looking at that sort of thing. I would also just reassure you, if some of you are on particular treatments that are funded by Pharmac, we've been told that if, for example, we need to pause somebody's rituximab for 6 months, just because we think that we don't want to bring them in and suppress their immune system more than necessary, we're told that Pharmac will be quite flexible about then extending that approval later. So if we do modify people's treatments, my expectation is we'll be able to then review that later on, go back to Pharmac and get the criteria modified or the approval lengthened to make sure you can then complete that treatment and you're not left at a long-term disadvantage from that. So Pharmac are very aware. They have actually been very cooperative with that. There's 1 or 2 things we've asked for that are more expensive drugs where they've balked and said, hang on, a budget doesn't extend to that. But I think they are looking at some modifications. And yes, you may find your clinicians may recommend a pause in treatment and say, well, we pause it for 3 months and resume it later, or we'll switch it temporarily or remove the component that's given in hospital, or we'll find a way to let you self-administer that at home and then resume it later on under the previous criteria. So yes, we may well see some changes to what we do. There's 2 questions, or one directly, one indirectly, about hemochromatosis. One person asking, are hemochromatosis patients more at risk? And another question was about somebody, I think, with iron overload after a bone marrow transplant. I don't think so. And I'm being very cautious about how I say that. I don't think so. I've not seen anything to suggest that hemochromatosis is putting people more at risk. There is a proviso. There's 1 or 2 risk factors for severe COVID-19 disease, which we've been a bit surprised at. One of them is high blood pressure, where we don't normally think of high blood pressure as being a huge risk factor for infections. And it may be that there's something specific about this coronavirus. It binds to a particular the way it gets into cells is through a particular receptor that partly has a role in blood pressure regulation. So there's 1 or 2 surprises, but I've not seen anything to suggest that hemochromatosis or iron overload per se is a risk factor. And in fact, hemochromatosis is one thing where, remember, we're taking the blood off really to prevent very long-term problems. So we're doing that to prevent heart or liver disease, perhaps 10, 15, 20 years in the future. So hemochromatosis is one thing where we're saying, actually, you know what? during community spread of COVID-19 disease, maybe it's better people don't come up to the hospital every week where you're going to be exposed potentially to other patients and staff, and we can just pause those venisections for a few months and resume them later. I think for the vast majority of people, that's fine. The main thing is that the venisections don't get forgotten forever. The only time I've seen people with hemochromatosis run into trouble once they've been diagnosed is really where, for some reason, someone moves house or doesn't attend a series of hospital appointments, or moves country and then doesn't get back into the system, then misses venisections for 5 or 10 years, and then the iron accumulates to a high level. So I don't think hemochromatosis is a particular risk, and that's the sort of condition where it may well be appropriate to pause venisections for 3 or 6 months, let this blow over, and then resume them later on, and just not be attending hospitals for that period. That's probably quite sensible. That's probably it right now. There's a couple more questions. Radiation therapist. Chronic myeloid leukemia on nilotinib. So it's a really good question, and one I'm not quite sure about. So chronic myeloid leukemia, we don't think is a condition with a huge risk. We don't have really good data on this yet. What we don't tend to see is huge rates of respiratory virus infections in people on the new tablets for chronic myeloid leukemia. The one proviso is that with nilotinib and imatinib, we do occasionally see hepatitis B reactivation. Now, that's quite a different virus to this coronavirus. So we think as long as your blood counts are satisfactory and your chronic myeloid leukemia is in a decent remission, probably not at very high risk, but maybe at somewhat increased risk. And one thing just to bear in mind is that a drug like nilotinib does have a risk of cardiovascular disease. So it's important to make sure that those other things like blood pressure are monitored, and cholesterol and so on. If you're taking nilotinib, that's usually part of the routine management of that. I would say it's possibly at moderately increased risk, and it would be reasonable to take some additional precautions if your job does involve seeing patients that may be at high risk of COVID-19 disease. That's definitely something to let your occupational health service know, and they may well want to make modifications for you to be deployed in different ways, which I think is what's happening for this particular person who's asked that question. Are lymphoma patients being screened for skin cancers during and after chemotherapy? So that's not necessarily COVID-19 disease related. I'll answer that question because I think it's a really important one. We know that anybody who's had curative chemotherapy for a condition earlier in their life, doesn't have to be a blood cancer, it can be a solid cancer, is at slightly higher risk of other cancers later in life. And in New Zealand, with the all the ultraviolet light exposure, we see quite high rates of skin cancers, often, fortunately, not melanoma, but often localized squamous cell carcinomas and basal cell carcinomas. And I really recommend that anybody who's had prior chemotherapy take particular care of their skin, and it's relevant to wear a high factor sunscreen and consider wearing a hat. Really take care. Imagine that, think about it as maybe that chemotherapy has aged your skin by 10 years beyond where it was. Are people specifically screened? No, we don't have particular facility for that. Generally, our dermatologists are recommending self-monitoring, but certainly people are welcome to either see a dermatologist every 1 or 2 years. You probably would have to pay for it yourself, pay $400 or $500 to have a thorough skin check. Most important, though, is that if you notice things, and it's usually on the sun-exposed areas, such as your face, ears, back of the hands, and possibly shoulders or legs if you ran around a lot in the sun as a kid and got burnt earlier in life. Worth checking those out and worth getting any lesions checked out. We do see somewhat higher rates of skin cancers in people who've had treatment for lymphoma and for CLL in New Zealand. And so that's quite relevant. There was another question here which wasn't particularly COVID-19 related, which I'll just quickly address. I work at the Malaghan Institute. Someone's asking where we are with CAR T-cell therapy. We do have a CAR T-cell, early phase CAR T-cell trial running. we've had to pause that at the moment with the COVID-19 situation, and because we've been having some difficulty manufacturing the cells, we are doing an early phase trial for relapsed and refractory lymphoma, and clinicians are aware of that. It's got quite strict inclusion criteria, and we're hoping we'll be able to bring CAR T-cell treatments more widely to New Zealand in the future. So that's my other non-clinical job, and we're working hard on that, and we hope to keep sharing updates with you, including through LBC. And LBC, I would say, are helping us with a number of elements to do with the trial. So thank you, LBC, for that. Brian asks, do people who have COVID-19 at a very low level can stay infectious past 14 days? Possibly is the answer. So there's a lot of questions at the moment about how long people are infectious for after they've had COVID-19 disease. What certainly seems to be the case is that people are most infectious while they've got symptoms, but you can also be infectious for a few days before and for some time afterwards. There's a little bit of confusion because some of the, there's two different ways of determining if somebody still has COVID-19. One of them, and the most easy way to test for that, is to do what's called a PCR, which is to look for the genetic information of the virus. Now, the problem with that is you can detect the genetic code of the virus even while there's no longer any actual viable virus there. So just looking for the genetic code doesn't necessarily mean you're still infectious. And certainly you can still detect the genetic code in some people for maybe 3-4 weeks after you've had the infection. Doesn't necessarily mean those people are infectious. The other element that we might just have to bear in mind, we don't have any different recommendations for people with blood cancers yet, but for other respiratory viruses like influenza, people whose immune system is weaker sometimes carry on shedding the virus for a little bit longer because it takes them longer to clear up the virus completely. I don't think that changes anything that people should do because we don't have evidence that actually leads to more infections being passed on. But it is prudent to perhaps be extra careful if you've had a blood cancer and have had COVID-19 disease to stay away from people perhaps for a few extra days. But we don't have anything to tell us that for sure, and it's not part of any official guidance just yet. We've had a question from Debbie, 2 years post-second bone marrow transplantation, and still on a treatment to raise the platelet count. So possibly, yes, still at 2 years, possibly moderately increased risk still, even though off immune suppression. That question also includes an element of questioning about aplastic anemia. Aplastic anemia is quite rare. We know very little about COVID-19 in any blood cancer, let alone in the aplastic anemia setting. But we know that people with aplastic anemia often are susceptible to developing low blood counts in lots of situations. And I would say that even after bone marrow transplants, some people with aplastic anemia have quite sensitive bone marrow function. And I'd take an extra precautions, and I would be reasonably cautious 2 years after transplant for aplastic anemia. Yes, I would take some precautions there. In the 70s with follicular lymphoma, doing blood tests put onto 3 monthly. So the first thing, there's a question there about surveillance blood tests. So one thing that we're doing as well is looking really critically at how frequently people have their blood tests and saying, do we really need to do these blood tests? So what we don't want to do is bring people into a community lab and put them in contact with lots of other people, break that isolation for a blood test that isn't necessary. And it is difficult. We don't really know where the risk and the balance lies. But a lot of you might notice that we say, actually, now's a really good time to review how frequently we do those tests. And your clinicians may say, actually, I think we can get away with doing it a bit less often. I think that's a good thing. We're just really critically looking at the benefit versus risk. Should I have them at the local path lab? I think there's a little bit of flexibility for most people. If you're having a blood test weekly, probably plus and minus a few days is fine. If you're having a blood test monthly, possibly plus and minus a week, either side of that is fine. If you're having it 3 monthly, I would have thought plus and minus a month either way doesn't make a great deal of difference. Ideally, check with your clinician. For us, in my own center, a lot of those queries are coming via our clinical nurse specialists. You may or may not have a named clinical nurse specialist who you can contact by email or text. And in our center, they are quite accessible and in general more accessible than us as the clinicians, and very well versed in what to do. And we speak with them very regularly. So if possible, check with your clinical nurse specialist. In general, moving a blood test, if you're on 3-monthly blood test, moving it a few weeks either way probably doesn't make a great deal of difference. My one caution about that would be if you're on a particular drug that needs monitoring, such as warfarin, then don't mess around too much with the timing. Another thing about community labs, I don't know exactly what each lab is doing, but you'll probably see first a lot of changes to the dates and times that community labs are open. So do check on your community lab's website before you go out for your blood test, just to double check that it's open, so you don't waste your time and make an unnecessary trip. Second, you may well find that they're spacing out the chairs. They may have a sign on the door, and they'll probably be telling people if you've got a cough or a cold to stay away. Sorry, I'll just draw the curtain because there's sun in my eyes. It's affecting the image. So they may have signs on the doors to keep people with symptoms out. They may well have things like hand gel for people coming in, and you quite likely will see that the phlebotomists are taking extra precautions around their own hygiene and the hygiene in the area that you have the blood taken. So just to reassure, if you really need a blood test taken, you need it taken, and the labs will be taking extra precautions to try and keep you safe during that. What medications for blood cancers will be changed to potentially less high-risk ones during COVID-19 risk? That's a really good question. So there's a few treatments. Some treatments we think are more immune suppressive. So we think they affect the immune system for longer and more profoundly than others. So the types of examples that we're at least reviewing or considering are for indolent lymphomas, there's a drug called bendamustine, which is a really great drug and gives a longer time to next treatment than our older traditional chemotherapies for, say, follicular lymphoma. We do know, though, that bendamustine tends to impact the immune system for a year or two after it's been given. We don't know yet whether that increases COVID-19 disease risk, but some people are advocating using the more old-fashioned chemotherapies rather than bendamustine right now. As I say, that's at the moment, it's just on a clinician opinion rather than any firm evidence. So I'd check with your doctor, because obviously if you don't respond to those normal treatments, then that's possibly worse, because then you might have to go and have something even more intensive. Other examples, for some treatments, there's a drug called venetoclax, which is now being funded for relapsed CLL. We're starting to recommend that people who start that, you would normally add a second drug called rituximab to that to deepen the response. We're postponing the rituximab component until this has passed. So we carry on the venetoclax, get the leukemia in remission, and we're just postponing the rituximab component by 6 months to try and reduce the immune suppression. That might be less appropriate if you've already started the rituximab, where that option might not exist. There are a number of potential examples elsewhere. So a lot of the sort of more indolent conditions, by which I mean the blood cancers that tend not to progress as rapidly, we often have the option of reducing the dose of treatment or spacing out the treatment more to reduce the overall amount of immune suppression. And we can often do that for 3, 6, 9, even 12 months, and then continue the treatment or escalate it again later without any major effects. What I would say is that for the more aggressive cancers, blood cancers like acute myeloid leukemias or aggressive lymphomas, we don't really have that option. We know that unless we treat that cancer with intensive chemotherapy now, there's no chance of it being cured. So for those aggressive blood cancers, we really are generally sticking to the regular treatments. It's more for the indolent ones, chronic lymphocytic leukemia, myeloma, follicular lymphoma, where we're backing off a bit on the treatment intensity, because we don't think there's any likely to be a major long-term downside to doing that. Myeloma, beaten all treatments and off treatment. So if you're off treatment, that doesn't mean you're not at risk, and it doesn't mean it's not important to carry on taking precautions. So even if you're off treatment and you've been through lots of different therapies, it's still sensible to look after yourself. There may still be other treatments that you're on, even if it's not directed at the myeloma itself, to treat symptoms. For example, pain relief, also drugs to protect the bones and prevent bone fractures. They can still be very important and very beneficial. So those types of treatments may well still need to continue. And some of those, there might be oral options or patches instead of injections that could be beneficial. Chronic lymphocytic leukemia, watch and wait. Are there additional measures? I recommend if you've got CLL and you haven't yet had treatment, that you, I still recommend the influenza vaccine, because people before they've had treatment for CLL can benefit from flu vaccines. The other vaccine that's helpful for people with chronic lymphocytic leukemia before therapy is the pneumococcal vaccine, or the pneumonia vaccine. Unfortunately, you may have to pay for it, but there's a particular pneumococcal vaccine called Prevnar or PCV13, and in a lot of international guidelines, that's recommended for people with early stage CLL. It won't prevent COVID-19 disease, but it can help prevent another serious cause of pneumonia. There's a mild, often a mild suppression of the immune system, even in early stage CLL before treatment. Not a very, very high risk condition, we think, but it could be worth just making sure you're on top of those vaccines. Having myelodysplasia, looking at into transplant options next month, will it be likely delayed? Possibly. So we are carefully looking at the risk benefit of bone marrow transplants, because we know that after those type of bone marrow transplants where you get cells back from someone else, that the immune system is very weakened for at least 3 months after the treatment, and probably for more like 6 to 12 months. And so, yes, we are often looking carefully at the risk benefit. That will be very personal to you. So if your myelodysplasia is quite aggressive and is on the cusp of turning into an acute leukemia, that may push the docs towards saying, actually, we better get on with it. If, on the other hand, it has fewer risk factors, they may say, actually, we could probably postpone this by 6, 12 months without major risk. And so I think that's very, very individualized decision, and I'd recommend that's the kind of thing that you check with your bone marrow transplant center. The other consideration for bone marrow transplants, I would say, is that there's a lot of difficulty getting stem cell donors from overseas because of the issues with overseas flights. There's not the flights are not only are there very few of them, but they're also now quite unreliable. And bone marrow transplants where we get cells from overseas, it's very time sensitive. So they may be looking at alternative donors for bone marrow transplants, or at doing some other tweaks in which that we sometimes collect the cells early and freeze them down. So that's something that's very much individualized as to whether or not to go ahead with a bone marrow transplant. I would reassure you that I know my New Zealand bone marrow transplant colleagues have been working closely in conjunction with colleagues in Australia, and they have developed some guidance and considerations that are based on best international practice to make those decisions in a very, very careful way. So people aren't really just making these decisions on their own. We're actually working closely with centres across Australia and worldwide. If your immunity is resetting after a bone marrow transplant, could this mean we're more like a younger person in how we react to COVID-19? What a good question. I really, really do not know. We don't know why young people, children, are so protected against severe manifestations of COVID-19 disease. We do not know. We don't know if it's something about the immune system, if it's something to do with the organ function, like the heart and lung function. We don't know that. So I can't say. I wouldn't want to make that assumption. Maybe. With the news saying the World Health Organization may change their recommendations about face masks, could you let us know what we should be doing differently? So this is one where I've disagreed a bit with the Western dogma that face masks aren't helpful, simply because if you look at the countries that have had similar diseases before, like SARS and MERS, which were both coronavirus diseases. SARS was in 2003 and MERS was in the Middle East in about, I think, 2009, right? Those countries, to control that, used look at China, that does seem to have used had good results with controlling COVID-19 disease, there is very widespread use of face masks. So I think that the recommendations are going to shift in the West towards using face masks more widely. I think there are several benefits to face masks. Perhaps the most important one is for people that actually have the disease but don't know they have it yet. So it seems that you can start spreading it 1 to 3 days before you have any symptoms. It stops those people coughing and sneezing. So a lot of the protection might actually be the people wearing the masks don't spread it as much from themselves. There's probably a little bit of the other way around. And as much as anything, when you're wearing a mask on your face, it makes it very hard to touch your face and your nose. I think there's another broader benefit, which is it's kind of like a social distancing signal that helps encourage people to take the whole thing seriously. I suspect we probably will move towards more mask use. They are going to be quite difficult to get hold of. Ideally, if you're going to wear a mask, wear a surgical one. I'm not as convinced about the cloth masks. There's a bit of a risk that if they get wet, they might actually harbor bugs. So if you did have them available, I've started seeing a lot of people wearing them around in the community. If you have them available, sure, wear them. They are quite difficult to get hold of, and I suspect we'll see more use in the future. I wouldn't be surprised at that. Can COVID-19 be picked up in a blood test? So yeah, yes and no. We don't yet have a blood test that can detect immunity against COVID-19, but there are tests that have been developed. At some point, those will become available and we'll be able to say who is and is not immune. You can apparently pick up small amounts of COVID-19 genetic code in the blood, but it's not known to be transmissible via blood. But we're not currently using blood tests to detect it. It really is about nasal swabs. Some of you might have had those before. It's not very nice. So the best way we're doing a nasal swab is take a firm swab from the back of the throat, which makes you gag a little bit, and then we use the same swab and take a firm swab from the back of the nose. The reason we use the same swab is that we get more chance of picking up the bug with only one test and with only one swab, because one of the constraints on testing is having enough swabs and enough testing capacity. We want to make sure we get the best result possible, and we think it's better to do the mouth and then the nose. It's not very nice to have your nose done and then put it in the mouth. So that's the way we're doing it at our hospital currently. It isn't very nice, but that's the best way of doing it. You can also detect it by putting a tube into the lungs, but that actually risks spreading the infection more widely, so that's not widely done. I've had the pneumococcal vaccine as no, I've had the pneumococcal vaccine, the 23 one, as no 13 available. Well, I need the 13 at some stage. The 13 in general is thought to be better as the first dose. Ideally, get the 13 later. So there's two pneumococcal vaccines. There's one called the conjugate vaccine, which is also called Prevnar or PCV13. Sorry, they got horrible names. Ideally, that one first, and then the one called Pneumovax, which is also called 23 ppv, or the polysaccharide vaccine. I'm sorry, that got awful names. But yes, ideally get the Prevnar PCV13 later at some stage when it's available. Availability of a lot of vaccines is an issue at the moment. Just finished 4 months of bendamustine and rituximab for CLL. Recommended I pause my treatment because I've had good results. What's your opinion on seasonal flu vaccine? So the vaccine responses within 6 months after the last rituximab dose probably are not very good. On the other hand, for this year, I probably wouldn't recommend having the flu vaccine because it might give some benefit. I probably would hold off the pneumonia vaccine just for now and have that next year instead. I'd agree, it's quite common that we're now holding off further treatment a bit earlier than we would before. And if people are getting into a good remission after 4 cycles, we might stop there rather than give the last 2. We can always give something else to treat the CLL if it relapses, and we might save you a lot of suppression of the immune system over this coming winter. The other things to bear in mind after the bendamustine is there is an infection risk that carries on for some time afterwards. So I would take all the precautions and regard yourselves within the first 3 or 6 months of bendamustine as being in that group that's effectively on chemotherapy. That doesn't make a difference now because the recommendation is for us all to stay at home pretty much. But if or when these restrictions are relaxed, the government might say, okay, people can start going back into the community, but if you've got certain risk factors, you should still stay isolated. If you've just come off chemotherapy or currently on chemotherapy, they might be saying, actually, you need to stay and maintain the current restrictions for longer. And I would recommend you take that seriously if you've had bendamustine in the last 3 or 6 months. We might finish off fairly soon. I think we've answered most of the questions there, in fact. So I think we have gone through those. So look, I hope that's been helpful. I hope it's answered quite a few of your questions, and feel happy to make some additional comments. You can look at the Facebook site, and I'll perhaps hand over back to Matt. And if you want to say any words at the end, Matt.
Yeah, really appreciate that. That might be our Friday afternoon session with Dr. Rob Weinkove, and very thorough. We really thank you. We're absolutely grateful. I think I speak for all of our blood cancer community. Thank you for your patience with our questions and your time, and just just giving us a lot of good information. So we're going to have this link recorded and available back on links to you guys on emails and using YouTube and our Facebook group. So once again, I think people are either clapping or bowing in their living rooms across New Zealand. So,
well, thank you very much. And just to reassure you all, as a hematology community, we're all touching base a lot with our how to deal with COVID-19. We're really trying to get the right solutions. We don't have all the answers yet, but we're working on it very hard. And I know the government's working hard to avoid this being such a big problem here as it has been overseas.
Awesome. Great work. And that's a wrap from us. Take care, everybody. Go well. Right. Have a great weekend.
Take care.
All righty.
Bye now.
See ya.